Well, it looks like I get to bring this home for everybody, so I'm standing between you and the concert tonight. But I really want to thank Hint for the opportunity to come. This has been really a remarkable conference. First of all, top-notch the way it was scheduled, but the content, the collegiality has been really remarkable. So let me grab the way in the back there. So Melissa recently lost her husband. That put her on a very low income situation, and she remembered, or actually she had to come into the new DPC because it was one of the incentives from her insurance company. When she came in, she basically said, well, I'm just here because I have to be. I can't afford any tests or anything like that because my husband died of my low income. That's when our staff told her that, well, this is all free and you can get this. And they identified her financial challenges, so they referred her to something called the Connection Center, which I'll talk about in a second. Tom was a 42-year-old gentleman who hadn't seen a doc in over 2 years. His employer just brought on a DPC, and as a consequence, he was diagnosed with hypothyroidism, prediabetes, and hyperlipidemia, and so treatment ensued. So I spent some time talking to our staff about some patients, and they shared those stories with me. And the things they have in common is that their employers invested in the health and well-being of these employees, and as a consequence, they were seen at Hancock Wellbeing at Work Direct Primary Care. And I think that the path that we have taken as a hospital to end up at a direct primary care is one that's, I think, interesting, and how I ended up here is a bit of an interesting story as well. So I'm an internist, and I've actually been employed by Hancock Health for about 35 years. I was a traditional internist back in the day when we did office, hospital, critical care. I did that for about 25 years. I was the chief medical officer for about 18 years. And about 2 years ago, our CEO asked me to move over into a different seat called the Senior Vice President of Employer Strategy. I said, sure. And then I went on to say what that meant. I didn't even know what an insurance broker was at the time. But I wanted to just also talk a little bit about Hancock Health. And when Deb Moore was talking about you have to love your patients, one of the things that I didn't include in my presentation, but I think is important, is that we have a kind of an unofficial motto at Hancock Health, and that is, what a blessing it is to work at a place where you love patients for a living. And so that's really true. We also have in our mission, our vision statements, the word kindness, and those are not mission and vision statements that just go into a book or go on the wall and nobody pays attention to them. When we receive feedback from patients, they specifically use the word kindness on a regular basis. I also think it's kind of fun to show the original 1951 hospital that was there as well. So just a little bit more about Hancock Health. We are a hospital in East Central Indiana, and if you're fans of the Indianapolis 500, that's where the Speedway is on the other side, and you can see that our service area is most of East Central Indiana. In addition to the hospital, we have several other facilities throughout Hancock County. And if you look at the one just to the left of center there, that's what we call Hancock Gateway Health. And that's particularly important because we built that and opened it about 2 years ago, and it is specifically built as a separate company from our hospital for the sole purpose of providing low-cost imaging and low-cost labs. So yesterday, Matt talked about having to get a mobile MRI coming to their facility to get a $600 MRI. Our published price here for an MRI is about $700, and if anybody wants to come and do direct contracting, I will beat $600 for that. Just a little bit more about the hospital. We're a 79-bed acute care hospital. We have about 1 million different kinds of visits a year and about $260 million annual budget. These are the specialties that we have. We don't do heart surgery, we don't do trauma, we don't do neurosurgery, but we have a lot of other specialists that are represented there. And these are just some of the things that the hospital has been recognized for. And I want to point out the Leapfrog group, and I'm not sure if you're familiar with that, but that is important because it is actually an employer-sponsored group that was started back just around the 2000s, and it identifies cost and quality, and they grade hospitals on that. So Hancock Health has been a grade A hospital for 8 times in a row, which is actually 4 straight years. There's only one other hospital in the state of Indiana that's done that, and that is a system hospital. And as you can see from the map in central Indiana, there's very few hospitals that are A-graded when it comes to quality and safety. We also have a partnership with Ascension St. Vincent Heart Center, and so we have an interventional cath lab. And so the cardiologists that staff that and do interventions there are from this heart center, which is ranked #1 in the state of Indiana and #2 in the nation. We also are part of the Mayo Clinic Care Network, and this network gives us the ability to access a lot of resources from the Mayo Clinic. For example, if we had a patient in our DPC or in our primary care practices who had a complex diagnosis and we wanted a second opinion, we can get a Mayo Clinic e-consult, and that is free to the patient. We don't charge the employer, we don't charge anybody else for that. So anyway, enough of that. Then the other thing that the hospital has done that I think is important is develop something called the Hancock Connection Center. And so if a patient has a social need or has a behavioral problem and you don't know where to call, you call the Connection Center. And what the Connection Center does is its job is to know and to connect people to resources within the county. And those, there's something called a system of care, which is kind of a central clearinghouse for all different types of resources. And these are some of the things that they can help with as well. This is for county residents, this is for employees of Hancock Health, and it's also for patients of Hancock Health. So just a little to level set you on the hospital. So I got this new gig. I was supposed to be leading employer strategy. Apparently we'd had this thing called EBC, Employer-Based Clinic, for a while. We had 6 clients. We were kind of using part of a couple family practices. They would take a couple hours a week and they would serve these patients. So as I started to look at this, the first thing I decided is we needed to get a dedicated staff and we needed to find dedicated office space. However, after that, we came to the realization that we needed to decide, what is our purpose? What is our role in doing this? And so the first thing is that we wanted Hancock County to become the healthiest county in the state. We went from the 25th healthiest county about 10 years ago, and just this year we were named the 3rd healthiest county in the state and the 117th nationally. The other thing that was important in the work that we were doing is to earn the trust to be the destination healthcare system for employers and employees in East Central Indiana, and to do this by providing great access and excellent experience, high quality, and affordability. So everything that we do is to try to drive these 2 things, and one of those things was to find a way to direct primary care. As a primary care internist, the other thing that really caught my attention as I started to look into this employer strategy was the fact that a lot of people who had good health insurance were not seeking primary care. In this example, 41% of people hadn't seen a primary care doc, or probably any doc, in over a year. And I think somebody, one of the earlier talks mentioned that employers pay for health care for half the population. So if we wanted to improve the health of Hancock County, there's no greater place to work than with employees who 50% of them don't even see a doc. So again, as I started my journey and didn't really know anything about it, I learned things from talking to people, and somebody pointed me to this book. And this was a great primer to try to learn about a lot of definitions and a lot about the structure of employer healthcare and how it works. And this really focused on employer-sponsored healthcare with medical centers, they called them. But it's really about employers learning that they had the ability to impact their healthcare by controlling things like benefits advisors, PBMs, TPAs, et cetera. So that was a really great start. The other thing that there was a great opportunity, which just happened because a friend called and said, hey, let's go to this meeting, was to go up to Rosetta Fest. So drove up to Navy Pier, went to the meeting. I sat through about 2 or 3 meetings, and then I realized that, a guy from a hospital, I should have brought my Kevlar for that meeting. But all kidding aside, it turned out to be a very pivotal and very important meeting. First of all, I met some good folks from Hint Health. I started following Beth's LinkedIn page at the time. But I distinctly remember listening to a talk by a DPC physician. And in my brain, I had heard the term, but didn't really know a lot about it. And we had this thing called EBC. So I remember going up to him and asking him some questions. And he goes, Mike, you have a DPC. And so a light bulb went off with me. And so I went home and I basically changed the name of our DPC to Hancock Wellbeing at Work Direct Primary Care. And I began to educate our CEO all the way down to our entire staff, so we don't use the word EBC anymore. We are a DPC and we use that. And I think it's important that we didn't go out there to say we want to become a DPC. We did the things that that our team thought made sense for what we were trying to do, and we ended up in the space of DPC because it makes so much sense. So shortly after the meeting, got home, and we had just earned our first contract with a new school. We had our new model in place that had different pieces. We got that up and running, and it felt like we had turned the corner and things were going very well. A few weeks later, I opened up my email and I saw this, this LinkedIn post from Beth. It said, "No hospital and primary care marketed as DPC is not advanced primary care or direct primary care in any way." So I said, So, you know, rather than debating her online, I sent her a message and said, hey, can we talk? So we had a nice virtual meeting, and I said, Beth, we have put together a program where we have a near-site strategy. So we've paid for the bricks and mortars, and we have 4 locations throughout Hancock County. 3 of those 4 are our dedicated space for our DPC, and one of them we're still sharing some space in a family practice office, but it's our staff that's doing that. The other thing we did is we adopted a lifestyle medicine philosophy, and you're all familiar with the 6 kind of pillars of lifestyle medicine. And we did this because our dedicated medical director is a lifestyle medicine certified physician. And the nurse practitioners that she brought in to work with her have all been trained in lifestyle medicine as well. And this is their full-time job, is working in our DPC. Now, the scope of services for our clinics or for employees, spouses, and dependents includes the usual things that you all include, primary care, virtual care. We also include health coaching, and that's basically included in the fees. We navigate patients back to the connection center I talked about if necessary. We do pass through the costs for immunizations, medications, and labs, but the labs are deeply discounted. It's our hospital cost plus a very small margin. We pass our medications directly through. We also have, we'll do biometrics, and we have a clinical exercise program, which I will talk about in a little bit. And then we really believe in using the data, running population health, and then working with benefits advisor and communicating with the employer about their data. And so getting back to the philosophy of lifestyle medicine, we wanted to have a strategy to make sure that we specifically addressed each of these. And so when it comes to healthful eating, we all probably know that dietitians are very hard to come by. They can all do their own kind of DPC practice on their own, so they're very difficult to hire. They're expensive. So we have found a website called Full Plate Living, which our health coaches can guide people to, our physicians and nurse practitioners. And this is a really good start for patients to get started on healthful eating. And then if they need to go to a dietitian, we can bring that in later. These 4 here then are ones that, in addition to our lifestyle medicine trained physicians and nurse practitioners, our health coaches are critically important here. So as physicians, as I was getting into this space, there were some things that I was learning as well. And when it came to the importance of relationships, I ran into a really interesting data on that, where if you look at this here, this is relative mortality. And if you lack social connections, that has a greater relative mortality than smoking 15 cigarettes a day, and then you can see the other things there. That is really astounding. And then this data also goes on to explain the reason for that, the biology, the psychology, and the behaviors that drive that, which again is very, very important. And this is actually from the Surgeon General had a publication last year on the epidemic in loneliness and isolation that has this data, which is very compelling. So this is where our health coaches come in. And so again, I think the best way to share the value that they provide is basically to just share some feedback. My coach is amazing in helping me see the positive in myself. While I'm seeking weight loss, they spend time talking about everything else, and that ultimately leads them to help with weight loss. They don't push me into places I'm not ready to go. And this is my favorite one here. And this is a text between one of our coaches and the patient. It says, "I love our sessions together. I don't know if you know this or not, but the work you do is life-changing. So important. Thank you." So that is really part of our strategy to change that part. Now, the other one is physical activity is very important. And again, look to the data on that as well. So this is Dr. Ashley, who is the new chairman of medicine at Stanford. And he's also an exercise physiologist researcher. So he and a group recently published an article in Nature. And he published on X some comments about that. And basically, his first line there that you can't read says, exercise may be the single most potent intervention ever known. Again, a very powerful statement about exercise and how it should be integrated. And again, we mentioned earlier Peter Attia's book, Outlive. And again, looking at this data, so even if you go from doing very little, anything north of 0 makes a difference. So in other words, if you go from being a couch potato to a potato, you have made progress. So you can see there's some other data there as well, but needless to say, the data about the benefits of exercise is very compelling. So we prescribe exercise. And this is the 3 wellness centers that we have in Hancock County. The pictures on the top are this as our newest facility, and these are medically certified wellness centers. So they have to go through rigorous criteria to be certified. The staff in the facility basically designed to take care of patients who have medical problems. So if somebody comes into our facility and they have diabetes, hypertension, Parkinson's disease, our bachelor's and master's prepared exercise specialists are trained to take care of them, help educate them about the value of exercise, help set up a plan, but most importantly, help them feel comfortable coming to a place like this, because many people that have, they're overweight, they don't feel comfortable coming to a place like this. Then if you look to the right there, that is actually a family practice office. So in the third version of our wellness centers, we have medical and exercise co-located in the same building. So if you look in the upper level, there's a dermatology office, there's shelf space up there, actually shelf space for the DPC when we grow enough to have our own space in this location, but also in the back is a family practice there as well. So we have something called a clinical exercise program, and basically for each DPC client, we give them 8 weeks, 3 times a week with one of our exercise specialists, something called a clinical exercise program. And you'll notice there that we also do, in-body when they come in, and we also can do VO2 max if we need to as well. So I think the comment made yesterday about VO2 max is important, and we integrate that as well. So this is a very important way that we weigh in with exercise. So the other thing that we do to try to kind of walk the talk a little bit is that if a employer, and again, our DPC is only for employers, if an employer is willing to pay $5 a month, we're willing to discount our fees $12 a month. So that means a $50 a month membership, which is what we normally charge, is available to the employee for $33 a month. So this is really just our way of saying how much we really believe in exercise, and we want to do something to try to make sure it gets done. So the other thing that we do is we collaborate with the benefits advisors, and they bring in the claims data, we bring in our clinical data, and we try to analyze that in the interest of improving the care of the patients and also lowering costs. And so we will meet with an employer, and this is the kind of data that we will show employers. You know, there's engagement data there. We can look at the number of visits. We can look at the number of health coaching visits. The blue line represents optimal control. Of the far right, the yellow line represents, and each on the bottom there, you can't read it, but that's A1C, that's blood pressure, that's different clinical parameters, and it just shows them graphically where their population lies. And then over here, we can take and say, for example, you've got 194 patients that have a BMI greater than 30, and then you've got 36 that have, can't even read it back there, 36 that have obesity, with hyperlipidemia, and then 11 that have all 3 of those. And then that gives us the ability to really focus on that. And this is all data that we pull from our EMR, and we really believe that the employers need to see this because they're the ones investing in the health of their patients. So really we have this thing we call the infrastructure of well-being. So this is all the kind of the services that the hospital provides, and we can kind of wrap the amenities I talked about. We've got low-cost imaging, low-cost labs. We've got the DPC. We've got the Connection Center to help folks as well, and we obviously have a full-service hospital also. So after Beth and I spoke, a few weeks later, she posted on LinkedIn again, and she said, I was pleased to learn about the DPC offering of Hancock Health in Indiana. They embody the DPC ethos, dedicating full MD and NP resources to DPC, offering a full primary care benefit to local employers at the community hospital. So I felt like this was a big win, given the respect I have for Beth, for Hint, and for what all of you do. Now, there's other hospitals that are doing some good work in this area as well. So this is actually an article that was published, I think it was last summer. And this is about a DPC clinic in the Carmel Clay School System. And it's a on-site clinic run by Ascension Health. And the reason I think this article is important to us is that they have many of the same amenities that we have. They have a lifestyle certified medical director. They have health coaching. They have all the exercise and things like that. And the data that they produce is very compelling. So they showed that, and this is actually over 8 years. So they've compiled this data for a while, and they actually used a company called Vital Insight, which is a data aggregator and analytics in this space to help them do the study. So they decreased polypharmacy, decreased A1C, decreased ED utilization, decreased inpatient visits, and this is the most compelling piece of data there. They saved $8 million annually on a $25 million spend. And now part of this is that they had negotiated some direct contracts with one of the health systems, it wasn't ours, to do total joints and things like that. So there's a lot of things that go into that, but nonetheless, that was very significant savings, no premium increases, and the assistant administrator or superintendent who really shepherded a lot of this basically said, you take care of people's health and well-being and the money will take care of itself. So I think that's great. I'm sure many of you know Dr. Bricker, and as I was preparing to do this talk, I happened to catch this video that, they come out at like 7 in the morning. I caught this last week. Primary care is a threat to hospitals. And then as I read a little further, direct primary care that is employer-sponsored is really a threat to hospitals. So this definitely gets my attention. And again, you know that he likes to use his whiteboard. And on his whiteboard, he talks about the reason hospitals don't like DPCs for employers is that it decreases hospitalizations by 22%, decreases ED visits by 11%. And he has this kind of algorithm he goes through with like 800 patients, and therefore it's going to cost the hospital almost $300,000 in business. So that's okay. We have a kind of this running joke with our CEO at the hospital, and it's tough for me sometimes to go to the hospital and get price concessions and things like that, but all day long we can prevent our patients from needing the expensive hospital. And so we fully embrace the work that we're doing that we think is going to achieve those two top goals that I pointed out, making our county healthier. And when people need care, we would like for them to choose us, but we have to earn that trust with the things that I mentioned before. So where are we now? What are we thinking about here? So we now have 12 clients. We've got 2,000 employees, and we have about 4,600 patients. And again, for those of you who have gone out and tried, so I'm an internist turned salesman. And it has been, and I was chief medical officer 18 years, so I became very creative in figuring out how to get what I wanted, and I usually didn't take no for an answer. So I've gotten very creative in getting in to talk to employers, but it's still very tough. So we got our very first corporate client here a few months back, and if any of you have you remember when you were in college, and if there was a loft in your room, it was built by University Loft, which is right down the road from where we are. So they just came on board, and it was really fascinating. They have about 40 employees on their plan, but they have a number of other people who are not on the plan. And one of the things that I think they actually suggested it to our team that went out and met with them, can we put our people without, that are not on the plan, can we put them on the DPC, and we would like to pay for part of it. So they've actually put, in fact, I think Tom that I talked about was a University Loft patient. But so they pay half of the fees for the DPC, and these other people pay the other half. So these are folks that probably haven't had health care, that for about $30, $35 a month, they now can get at least primary care. And then the other thing about getting into employers, and again, this is one of the things that we're doing in our employer strategy ecosystem is we are opening a occupational medicine practice. And that has been an amazing way to open doors for me to get into an employer, develop a relationship, and have a wider conversation. I have been amazed. I've actually been in talking to Walmart because of this as well. The other thing is and this has been fascinating for me because some of the talks hit right on this. I've got 2 employers we're talking to. One has about 15 locations in the Midwest, and another one has 5 locations in Indiana. They seem interested in the model, but they're very concerned about not being able to spread it elsewhere. So some of the talks we had here are very, very relevant to this, and I'm actually very interested in trying to see what we can do to bring that network together through Hint Connect. The other thing we're doing, and again, some great talks on this as well, is, so the data that I've read suggests that there's between 11 and a 30% savings in the total cost of care with DPC. And so I feel like that savings, there ought to be a way to get a health plan to sorry about that, get a health plan to embrace that, repatriate the savings back to the employer as well. And the other thing that's important is we are taking care of our own hospitals. So we as the DPC take care of the hospital patients. So you can imagine that was a challenging negotiation. We also put a health weight management program in place. It's not a GLP-1 program, it's weight management. And so these are the criteria. And so you may have figured out by now that I'm a lousy golfer. Pickleball is way too dangerous. So how do I get my exercise and my social connections? I do this about 3 to 5 times during the summer as well. Happy to take any questions, though we may be out of time. And if anybody wants to contact me, that URL will get you to my email as well. And it's been a pleasure, and thanks for the opportunity.